it's a little after 1, so we're going to go ahead and get started. Thanks everyone for joining us. This is our first live Zoom training, and so we're excited to provide this training for you and not have you travel and have it be live so you guys can have an opportunity for questions. But my name is Heather Brandt, and I'm new to the Behavioral Health Division. Some of you might know me through my prior work experiences. I was also a provider in free-through recovery, and now working on building the extended free-through recovery program in our state. So then I have Eric here with me.
Eric Boness, I'm the lead administrator for free-through recovery. I'll be responding to questions in the chat and giving a little bit of input on some of the training.
Okay. So just a few housekeeping things for today. I can still hear a lot of back noise, which means that people aren't muted. So if you can please make sure and mute. You'll see a little microphone typically at the bottom of your screen, I believe, and you'll want to click on that to mute. This training is going to be recorded, and so we will also have it available afterwards via the DHS website. Now for questions, as we're going through the training, I would like for you to please send a chat to Julie. It says Julie Huey host. If the question is pertinent to the topic, we're going to try our best to answer it during the topic. However, if it doesn't pertain to the current topic, we will do our best to answer at the end, okay? So the plan for these trainings is that we'll be providing these trainings on a monthly basis, and then if you're not able to attend the live training, you'll be able to watch it as it was recorded, and we prefer that you watch them before your next regional meeting. All right, so let's jump right into it. So we're talking about documentation today, always a great topic of conversation, something that's certainly not always the most fun topic, but I want to talk a little bit about why it's important. On this team of free-through recovery, we work on a multidisciplinary team. We have the parole or probation officer, we have the DOCR, Allie, we have Dr. Peterson. We need to be able to know what's happening in the Behavioral Health Division, and we need to be able to know what's going on with any current participant at any given time. And so if your documentation isn't there, it's hard for us to be able to determine that without making a phone call or asking via email. Really talking about the value of person-centered care. Eric and I talked a little bit about this more, is we don't want to have to continue to poke and prod at clients. I just heard my slides aren't moving, sorry. There we go. So we want to be able to provide person-centered care, which part of that is we don't want to have to continue to poke and prod at clients about past or their same questions over and over again. If they transfer to a different care coordinator within your organization or they change providers, it's very helpful to have that information there so that you don't have to be asking about it again. All right. Another reason documentation is important is because it's how we deem if you're eligible for payment. I put all the standards in here so that you could reference to this if you wanted to, but we use your documentation as administrators to determine if you should be paid. So I don't have to read through all of these, but you should understand what's expected. So if you're not making weekly contacts with the participant or you're not having an agreed upon meeting, we don't know if you're not meeting the contact standards or if that's what the participant wants. And so a lot of times we're doing a little bit of guessing there. And so that should be clear when we're reading your case notes. One thing I talked about here too is contact should really be driven by the participants, by the care coordinator, not the participant. It's the care coordinator's responsibility to reach out and engage with the participant. However, if the participant does reach out, that should be documented as well. All right, so what we're going to cover today is case notes, big one, care plans, strengths and needs, releases of information, outcome measures, billing, and discharge requests. All right, do we have any questions so far, Nikki? Okay. All right. Not sure where that went. Just trying to make sure I can see the chat while you guys are in here. I did. I think it's behind that. Here it is. All right, good. Now I can see your chats as we continue to move along. It's a lot of multitasking for me. All right. Oh, Eric just pointed out to me what I'm doing wrong. Okay. All right. Have to click over here. Okay. We'll have to go through Nikki. All right, so types of case notes, I wanted to kind of briefly go through these. They're also called a chrono. We have attempted contact. And I'm not going to spend a lot of time explaining these unless they're in one of the areas that we see some of the errors in. The collateral contact. This is one that we do see a lot of errors in. This is when you're making contact basically on behalf of the participant, and it's somebody that's not on the care team. You have a face-to-face visit. These are your care coordination meetings and your peer support specialist meetings, and they are in person. You have a no-show. So if somebody is scheduled for a meeting and does not appear, that would be a no-show. Offender communication. This is phone, texting, messaging, treatment staff. And then you have care coordination team. One of the mistakes we see often is that care coordinators select offender communication when it's a face-to-face visit. So you want to make sure that when you're face-to-face with the participant, that is a face-to-face visit, not a care coordination team. Now, like let's say you're doing transportation services at your provider location, and part of that is not really that care coordination meeting, it's just strictly transportation. That should be a care coordination team note. And then to talk a little bit about the drop downs, the risk, those are your LSIR domains. And so basically you can select more than one, but you want to maybe just stick to the one that you're mostly talking about or addressing during that meeting with the participant, what you're addressing, and then the type, which is what we talked about. Any questions so far? Correct, yes. The participant cancels your meeting, you can type in as a no-show, and then put in the chrono, the body that the participant contacted you and canceled the meeting, and then usually people will put when it's rescheduled for.
I think what might be better just to help us see is mark it as offender communication and then put that they canceled. A no-show would be one where you're sitting there, like they did not call ahead. They're supposed to be there for the appointment. You've carved out the time and set the time aside, and they did not show. If they call ahead to cancel, put it as offender communication and just document in the chronos that they canceled, so that we can delineate the difference between and give you guys credit, especially for the times that you're setting aside the 30 minutes or an hour and they're not showing up.
Yep. Anytime you're communicating with a probation or parole officer, they are part of the care coordination team. Or if you're contacting your regional or your administrator, or you're contacting Allie or Dr. Peterson or Mallory with the DOCR, they're part of the care coordination team.
One of the best ways to help remember that is the ones that are covered by the initial releases. So that's anyone with the behavioral health team, anyone with the Department of Corrections, and anyone with your specific providing agency.
So if you are strictly providing transportation to a participant, there's no other engagement. So I know a lot of times Eric calls it like a dashboard meeting. That is a good opportunity to have a very meaningful interaction with a participant. But if the face-to-face is strictly transportation, you're driving them there, dropping them off. I know sometimes those aren't even the care coordinators, there's somebody else with the organization. That should not be counting as your weekly contact with the participant. That is a transportation service.
You can go ahead and document it, but we're looking for engagement. So like Heather said, it needs to be some type of dashboard conversation related to their goals and care plan. How they're doing.
Yeah, there's a lot of times you driving them to a location, you're talking about goals, concerns, risks, you're making your plan for your next meeting. That's a good meeting. That's a valid face-to-face visit. Is that better? Clear? All right. So here I just gave an example of a case note that you guys could use for reference. One thing I want you guys to be aware of in this case note is that we identify Molly, the care coordinator, right off at the beginning. Molly, CC, and Heather met for our scheduled FTR meeting. We went to Caribou Coffee for 60 minutes. I kind of cover the structure of the meeting, and I'll give you guys a layout for what we're expecting in regards to case notes, and they don't all have to be this long. But I wanted you guys to have somewhat of a good layout to review there. All right, so here is our template for a face-to-face visit for care coordinators and also for our peer support specialists. So you want to ensure that you're selecting the date of the meeting in DOCSTARS, not the date that you're typing the note in. It will be time-stamped, but you need to make sure that you're selecting the date that you met with the participant. The length of your meeting, you should be reviewing goals, current priorities. You're not always going to address all goals in every meeting, but what did you discuss? Any updates? Keep it brief. Review progress, accomplishments, any new risks, concerns, or challenges. And then most importantly, when they talk about new risks, concerns, or challenges, we need to state what we offered. What resources did we link them to? What assistance are we providing? Sometimes when we're reviewing notes, for example, I'll see something like, you know, Heather is homeless. Okay, and then the next part of the note is, I'll see her next week. Well, I'm looking to figure out, well, what resources are being provided to this participant to address homelessness? If you're having any collaboration with service providers, that should always be in your case notes or as that collateral contact or as a treatment staff note. And then your plan for future. At the end of your meetings with participants, you should be setting up your next meeting date, whether it's tentative or it's in stone. But try to set that meeting up at the conclusion of each meeting and document that. A case note should always be professional. Try to imagine your note being read in court. You know, read it back to yourself and say, is this something that I would want to be read to a group of people? And then you should only really include observations if they're pertinent. So it sounds like something like, Heather appeared anxious today. She kept switching from subject to subject and she let me know she was feeling stressed. And then one last thing is to talk about is like, did I answer the outcomes when I wrote my case notes for the month? When your administrator is looking and reading through your case notes, they're trying to make sure that they can answer the outcomes. And so make sure that you're addressing those as well. You don't have to, you know, address everyone every week. Some providers do, and that's great. But through the course of the month, you should do that. And case notes really should not include opinions, slang, and I'm starting to see a lot of other participants' names within those case notes. Those should not be in there. Like, let's say somebody transfers to another provider, and then there's a client note with another participant's name in there. It's sort of like breaking confidentiality. Okay, we're just going to keep going here, and I'll give you guys some more tips to go on. All right, so we have case note, Heather and CC Molly met today. We talked about goals and plans for the future, scheduled to see again next week. What do you guys think is wrong with that note? If you were a probation or parole officer and you were reading through case notes on Heather, what do you think? You wouldn't have a very good idea about what was going on by reading that note.
Well, they
What do we have from chat? Can you guys hear Nikki?
No.
No.
Okay, so we talked about it. What Nikki said was that a lot of the feedback was it was too vague. It wasn't specific about the goals and plans. What else, Nikki? Okay, yeah, it's just a little bit too vague, right? So here's another one. Face-to-face visit, doing well, keeping busy, living on own, staying out of legal trouble. We'll see you again in 2 weeks. So what's good about this note? Okay. It does answer some outcomes, right? It tells me that they're staying out of legal trouble, that they're living on their own. Lists behaviors, yeah. What could be improved upon with this note? And these are notes that I used from actual notes, yeah. These aren't ones that I just made up. And if you're currently doing your notes like this, I don't want you to feel bad that this is how you're doing your notes. I want you to be like, all right, now that I'm aware, I can get better, you know, just like anything in life. All right. I have a few notes of my own. Proper documentation and grammar, avoid slang. There's a lot of times we will see abbreviations or acronyms. We don't know what those mean a lot of times. And I read a lot of chronos that do not have any proper capitalization or punctuation. It also, when I read the second note, it really sounds like a check-in mentality, like I'm checking in, they're keeping busy, they're living on their own, they're staying out of trouble, great. And we're gonna really be working with y'all as providers and care coordinators to get away from that check-in mentality and to get more to working to do risk reduction work and not just risk control work. The program is not built to just check in, it's to, you know, link and to address risks and needs. If a person just needs a monthly check-in, we'll talk about that at, in another section of the presentation today. All right. Few other examples here. You should always document face-to-face contact, but what about collateral communication regarding your client? Yes, document this too. So collateral contact, your family member, a landlord, a call for resources, and then give you examples of a good way to document text messages or phone calls. I have a typo in there if anybody sees it, sorry. All right. We went maybe one too many, but oh. All right. So additionally on case notes, and Dr. Peterson did cover this in her initial training, but she called it like opening a box. So if you open a box, you should close the box. So for example, you're talking about a client being homeless, you're talking about a client relapsing, you're talking about a client being unemployed. We need to know what resources you're linking that client to and what type of plan you're developing. When a team is looking through a note and it says, client is homeless, like I brought up before, and see him next week. You know, we want to know like what resource are you linking that participant to address the issue. Example, like they're having a relapse, they're attending AA meetings, they were referred to a walk-in appointment, you're picking them up for a meeting, whatever is pertinent to that participant's presenting issue. Then also linking your case notes to your care plan. So a participant can't get to work due to no transportation. Well, that triggers me that they should probably have some type of goal in their care plan in regards to transportation. Another area is when you put information in the case notes, please try to cite where you received this information. So for example, I was informed by the PO that. And then we want you all to use person-centered language. We know that in the drop downs when you're writing case notes, it says offender. Really the expectation from us is that in the case note, you use the person's name. This is more than fine and acceptable. Whichever name they choose to be, identified with. And then learn to stay away from generalized statements without facts. So client is playing games, client is manipulative. What does that mean? I don't know. When I'm reading something like that, I'm not sure what that means. Do you have any questions right now, Nikki? Correct. Yes, a phone conversation with the participant is offender communication. Oh. Okay. All right.
Did they register? Did they get the invite? There was a call-in number on there, right? They can try that.
Okay, so let's keep moving along here and talking about observations versus opinions. When you're talking about something like a client appearing to be under the influence, I read some things like the client was high, the client reported she had a slip, the client is acting high, the client is acting as though she is using, or he. What makes you think that? You want to be very careful that, you state things similar to the client appeared to be under the influence of a substance as evidenced by their slow, staggered gait and small pupils. Or the client appeared to be under the influence. She was walking with a staggered gait, switching from topic to topic during discussion and continuously moving arms. All of this behavior is not typical of my past observations. And so you're getting away from more of those judgmental statements to more of a, of a clinical or professional based observation on what you're seeing and why and what you're seeing, not just that they're high, okay? Or, the slip, like there is a lot of terms that we use, a lot of people use in the recovery community. You can say the participant reported that she had a slip. This writer discussed what occurred, and the participant stated that she had relapsed on meth after running into an old friend. Any questions there? No? Okay. All right, so we're moving on to the care plan. And what I look at when I look at a care plan, I look at it as like our template or our blueprint for their participation in free recovery. The expectation, so you meet with the participant within 3 days. You should have a care plan created within 10 days of the referral. You cannot create a care plan without meeting with a client, okay? I've seen care plans created and the participant's never been met with. This is their care plan, not your care plan, okay? And so we're gonna talk more about that as we move forward. And so it covers, the risk needs, so the 10 demands from the LSIR. And if you feel like you need a refresher on LSIR or that you don't remember what that means, you should be contacting your administrator or reaching out to Parole and Probation. They use those assessments all the time, but we can pretty easily explain to you what that is, not in today's training. And the status, what's the current status of this risk or need? The objective. The objective is the goal. What is their goal? The participants have choices. We need to use a collaborative approach. And then we have notes, which is space for free text. Helpful for reminders, updates, things like that. Okay. So kind of walking through, that's what it looks like in DOCSTARS. All right, so I'm gonna go ahead here and play a little video for you guys of setting up a care plan, okay? I can't hear it. Okay, so I'm hearing from you guys that you can't hear that. So I'm just gonna kind of cover it with you as it goes there. Hopefully I did it like this so that when it's on for watching later, it will be there. So what we're talking about here is that this goal is the client's goal. It's their objective. They can't hear that though, only we can. Yeah, right, Nikki? Yeah, yeah, yep. So I'm gonna kind of forward it here. So this is the client's goal, not our goal. So sometimes what I'm seeing here is like something in quotes or something that says like, Heather needs to get a job, okay? Heather's the participant. The objective needs to be from the participant's point of view. And so what is their goal, you know? And so if I was writing this, it might sound something like to obtain meaningful employment. Well, that sounds like me and not my participant. So after we talked through it, she decided that her goal was to obtain employment that she enjoys, okay? Now, the next pieces move into the activities. Now, activities are strategies that bring us closer to our objective. So if she's looking to obtain employment that she enjoys, some of the activities that we agreed upon, right here, were to, she said she has a resume at job service, but it hasn't been updated for a really long time. So is updating her resume at job service going to be an activity that's going to help her obtain a job? Yes. So we'll go ahead and we'll put that in under activity. All right. So then next is status. It's in progress. And usually I just select the date that we decided to work on that. So on October 11th, decided that we were going to start that. Now, when she completes that, you can go back in there and edit it and do an end date. Another strategy that we talked about is in regards to how many jobs a week is she going to apply for. You know, sometimes clients will give us really unrealistic numbers there. I'm going to apply for 20 jobs a day, you know, and it's like, well, are you really? So I really break that down, you know, I'm going to apply for 5 jobs a week. It's in progress. I'm starting it on Monday. Okay, so I put the start date October 14th. Now, as I was working with this participant, we started talking about voc rehab and exploring that as an option for employment training, or, you know, just kind of exploring her needs and interests. And but she wasn't sure if she wanted to do that right away. She kind of wanted to see what she found out there for employment. And so when we typed this goal, we did it as a pending status, meaning that it's pending. We haven't decided if that's going to be something we're going to really be working on right now at this moment. And so if later on she decides, yep, I really want to do that, we could change the status to in progress and put a note in there and move forward with it. And then, yeah, you can use that note section there to document different progress. You also want to be clear when you should date that, because sometimes it can become sort of just one big paragraph and you're not sure when it was wrote and who wrote what. So just putting in here that 10/17/19 participant obtained employment at Mid-State Trust starting 10/20/19, and then I always put my initials behind my work when I'm updating something, and save. Okay, Nikki, is there any questions on that so far? Okay. Well, thanks for bearing with us there. Sorry that audio didn't work. Hopefully that will work for the recorded version for everybody, okay? All right. Why is it going? Am I going the wrong way? All right, so your care plan, again, activity should be action steps that can be done to help the participant reach their objective. Specific, measurable, attainable, relevant, and time specific. So when you're writing your activities, they need to be relevant to that goal or objective. And so if transportation is a barrier with a job, sure, that is relevant, right? But would, you know, visitation with children, that's not pertinent to employment or something like that. You need to make sure it's relevant, okay?
Part of this training is expanded in the first documentation training that we did also, that Dr. Peterson, you can reference that on our website if you want to watch a more detailed training on smart homes.
And then I just did another example here. So risk need is accommodations, it's in progress. The objective, to get my own place, not Heather needs housing. This is the participant's goal, not our goal. You can actually you can work through the participants' goals with them. You should be working through them with them right with you. You also could provide them with some type of documentation or a form that could help them give input into their goals, and so that they know that they have a say in what they're working on. And so the activity is, you know, save money for an apartment and start looking for apartments. You know, it could be any activity that is pertinent to getting your own place. And so saving money, does it sound like we need goals in other places? Yeah, employment, financial, a lot of areas of need there. Just some more here. Objective, I want to learn how to live sober. Again, I state, ensure the objectives are person-centered. They are the participant's goal. When we state the goal as Heather will maintain stability in her recovery, it sounds like this is the provider's goal. You want to ask the participant what their goal is. Okay. All right, was there any questions, Nikki, on care plans? No. I feel like care plans are a big area of growth. But yeah, even, you know, I don't want to say one is more important than the other, but I think we do spend most time in the case note chrono section. But if you can be coming from a place of a person-centered goal, I mean, if you ask a participant, well, what are your goals in free through recovery? Why are you in free through recovery? Hopefully you can learn some of their motivation and reasons for participation as well. If they don't know why they're in free through recovery, then that means we probably didn't do a part of our role clarification for them, and we need to go back and do that. Okay, so assessment. In the assessment section, this is where we offer peer support. So we should always be offering peer support, and we should be revisiting it. It is a requirement of free through recovery to have peer support available to your participant. There's a lot of people that are not answering that question. It's being left blank. And so ensure that you are asking that question, offering peer support, and revisiting. I think sometimes our participants might be thinking that you care coordinator is their peer support, and vice versa. They're not understanding the roles there. And so it is helpful during that initial meeting and ongoing to clarify roles, to explain what a peer support does versus what you do. You know, as a care coordinator, we're linking people to resources, and we're, you know, kind of helping navigate systems. That's different from that peer support specialist. And as this moves over into, you know, when things, and I don't know how much of you know about like Medicaid billing, but if you decide, you know, that you're going to be a Medicaid provider in the future and providing care coordination, those two roles are extremely different. And so we're going to want to start, you know, making sure we're doing that now as providers in free through recovery, so it could be a smoother transition for those sites that are looking to transition to be Medicaid providers as well. So ensure you fill this area in, and then also requesting discharge. This is where that's at, but we will cover that in further detail later in the presentation. Is there any questions, Nikki? So Nikki's right over to my side here. We should have her get on camera so you guys can know what Nikki looks like too. Oh, she's shaking her head no now. I think we'll get her in here in a second. All right. Yeah, so needs and strengths. This is also a section that is sometimes left blank or is very brief. You know, ask the participant to describe their needs, ask the participant to describe their strengths. At the end of the intake or first meeting, you can review what the participant described and also add based on your intake assessments. And once again, do not fill this out until you've met with the participant. But many of you already do this during your initial case note. You have a template, that's great work. You can just go ahead and copy and paste that into this section, okay? And then I give a great example here of one of those. So again, it goes back to that intake. You know, what are your needs? What do you need help with in free through recovery? What do you need of? But then also, you kind of might gather some of your own thoughts on that as you're typing as well. And then strengths. I always ask the participant, what are your strengths? You know, it's not very often that somebody asks a person that, and they can often have a hard time answering. But dig a little deeper and have them come up with some of their strengths too.
I think it's also like when we think of the participants that we're working with, they may not feel like they have any strengths at that time. I mean, all they're thinking about is the crisis and the needs that they have. So as you go along and you're working with them, there may be a time that you're having another conversation and you pick up on something that really should be celebrated about them. A particular strength, like maybe just a very genuine passion and concern for their kids or something like that. Highlight that right there in your conversation and tell them, hey, I'm going to add that to your strengths in your care plan, because that's a healthy strength that should be celebrated in you, and we should look for ways to build off that. So sometimes it can be when there's not a lot of things to celebrate, maybe you know, this is something that you can highlight and help them see.
This is like, well, you're getting the participants' inputs, but this is really your intake assessment of their needs and strengths. So you should be asking the participant about what their needs are, what their strengths are. But this is kind of like your intake note, your impression of the participant following that. Mm-hmm. Anything else? No? Okay, so the next topic I think is a real area of need. Each provider is responsible for their own release of information. And so my advice today, it does not constitute for legal advice. So I just want to say that, but a good release of information, I gave you guys a good template here for what it should always include. So you guys have that there. Yes. Yes. So what this is, so I can go into that, is so they have the initial release of information through Free Through Recovery, right? That covers everybody on the care team. That's how they get referred to Free Through Recovery. But each provider should have their own release. So you need to utilize the release of information when you're discussing clients with anyone not in your own organization. During your intake, it's really good practice to bring some releases of information with you or your laptop or however your agency does that, and have them signed right at that time. So organizations, support persons, you know, I even asked, like, who's your, if I had an emergency while I was meeting with you, or there was an emergency, who would I contact? Like if your participant was having a medical emergency or something like that, who would I contact, right? And you don't contact that person unless there's an emergency. Or if you're gonna be facilitating a family, kind of a family session as a care coordinator and peer support specialist, should make sure that they've signed a release of information to those family members. Go ahead. Mm-hmm. No. So that release of information does not cover center or BTC. So if your participant is living at one of those locations or receiving services, I would have them sign a release of information when I was meeting with them. A lot of times those locations are also having them sign a release, one of their releases of information. But if you have it, great. You call, you can't get any information, you could say, well, I'll just email you my release of information right now so we can get over this barrier and you can start discussing that person. Mm-hmm.
Another question that often comes up with that is, does it cover human service centers if they're part of DHS? Technically, the Behavioral Health Division is under DHS, but we need a separate release. So the release that they signed when they were referred only covers the FTR leadership team, Behavioral Health Division, not services that they're receiving at the service center. So if you're staffing with someone that they're working with in treatment, you're going to need to have a release for that coverage. I know that can be confusing because some of us as FTR admins are housed, or our offices are at a service center, but there needs to be a separate release. I'm quieter than Heather, I'm sorry.
That's usually the case with me and most people. So if another provider or person calls you and you do not have a release of information, what can you do? You cannot confirm or deny that they're your client, but you can listen to the information the other person is providing. Sometimes they want to provide you with useful information. That doesn't mean you can't listen, but you could say, you know, I'm sorry, I can't confirm or deny that they're a client, but I can listen to what you need to say today, right? And then you can follow back around with that client. So you receive a call from a concerned family member, you don't have a release. I would circle back around to that client depending on the information that they were providing me, or you get a call from a provider. You know, you probably want to circle around to that client and make sure that you get a release so that you can follow back up. Okay, so just some tips and tricks. The release might be valid if it's missing any of these things. However, a recommendation on your release of information is you can put something to state like, upon discharge from free through recovery, the release is no longer valid. So that means that your site location doesn't have to monitor dates, okay? So I thought that was really good, useful information. Nikki, do we have anything else for questions? No? And if you're struggling as a location site to get a release of information, let us know. I know I have one from when I was a provider that I would gladly share, and you could change it to be updated to your organization. All right, so our next topic of conversation is outcomes. So we have the 4 outcomes that we measure. The first one is stable housing. And what I want to say right here when we're talking about outcomes is that we want to refer you to your provider guidance. I know in DOCSTARS, it says some things a little bit differently, but we want to use the provider guidance as your template for that. And that is what I referenced here, okay? So is the participant is considered to be housed if they're living in a place that meets their basic needs. Independent housing, living with a family friend, halfway house, etc. The treatment facility, it's pretty all-encompassing. Employment, if they're employed, if they're traditionally employed, if they're in school, workforce training, internships, receiving SSI or SSDI, say they're enrolled at a chemical health treatment center in a partial hospitalization or residential treatment, and they're living there, they aren't probably able to work, and so we don't want that to impact the outcome, okay? Recovery, this one's a little bit longer. Sometimes we will see differences here sometimes between that supervising officer and that care coordination site. So if you're checking yes for recovery, and it's because, you know, they've scaled back or they are engaged in strategies to reduce harm or any of those things, it's very helpful if you include a comment in that area so that we can understand that, because it can take a long time to scroll through all those notes and try to figure out why there's a discrepancy there. And then the other thing on that is when we're looking at outcomes, we don't have access to the probation or parole's notes, their chronos. So if they select yes or no and it's differing than what you've selected, they might know more information than what we know at that point. And so, but it can be very difficult to answer sometimes. And then law enforcement or criminal justice involvement. I think this is a good one for clarification here. I know that what it means is that law enforcement engagement resulting in booking or violation of their parole or probation resulting in incarceration. So technically, if somebody uses an illegal substance or something that violates the conditions of their probation or parole, that's a violation, but that technically doesn't mean that it's resulting in incarceration for that individual or revocation. Yeah. Yeah.
So for your client, what if a client is disabled and unable to work?
Yes. So the word, okay, so if they are on SSI or SSDI, that is yes, that counts towards that. But if they're trying to get on SSI and SSDI, not until approved, okay.
Yes, once they're approved.
Yeah, but I mean, like, let's say they're doing something else, an alternative to, you know, meet that need during that time. But basically the risk falls down to is that they also don't have any stability with finance, you know, and so there's a lot of unknown there.
And a clarifying question. If someone uses one and reports period because of their PSS or treatment,
So the question was, if somebody relapses once and then re-engages with their PSS and their treatment provider or whatever their plan was, is that a no? And the answer is, from my point of view, that is they're engaged back in recovery. They're engaging in strategies that avoid more serious problematic substances. But you need to include that in your comment section so we know why you're saying that. If it's just, we see a relapse and then it says, oh, they're engaged in strategies to reduce the risk. And then I read the note and I'm like, well, what strategy are they engaged in to reduce the risk? Like, I see that they're saying they might do that, but there needs to be some follow-up there, and there needs to be follow through on the participants as well.
what about
If they're on SSDI, that is still yes. That means that the federal government has deemed that they're meeting criteria for disability. Anything else, Nikki?
No.
No? Okay. We're still on time here. Just freeze recovery outcomes, data, and rates. Outcomes in DOCSTARS. So when completing your outcomes, I wrote please in big letters because it is so helpful if you include a comment. If you're saying yes, please include specific information to verify or back up your outcome, or even if you're saying no. Many times administrators are spending time reading, trying to verify. It's very helpful if you include a comment. So when your regional admin, or I should get away from the word regional, when your administrator is completing outcomes, they need to include an outcome. We actually can't click past that screen until we put an outcome in there. And so historically, you've probably seen like agree or PPO and care coordinator agree. But what we're also starting to include in that section is feedback for you. So providers, you should be looking at your feedback there and looking at what we wrote. If we're deeming it as base pay and you thought it should be performance pay, a lot of times we're explaining why it's base pay. If you thought it was base pay or performance pay and we're saying it's ineligible, we're usually putting information in there about why you were ineligible.
We're also making comments of anything, like it could be a heads up for next month. Like if we see that engagement is lacking and you're just barely making eligibility, then we'll put notes in there that highlight that for you. So if you don't read those, you could go into next month and be ineligible when the previous month we tried to highlight that for you. So please take the time to read those.
Right. We're not meeting the contact standard of weekly, and it is appearing that nothing is agreed upon, and we're doing the reconciling, and last month it was weekly. We might leave you a note that says something like, you know, increase your engagement to meet weekly standard, and we likely will give you base pay. But if that continues, a lot of times at that point, we're going to be doing an ineligible the following month.
So we want to back up to the answer before about
Mm-hmm.
They want a little bit more aggressive with that one. If the PCI and the PO, I was or if there's a cost of
Okay. So if they're applying for SSI and SSDI and they're not doing anything to increase their financial stability or productive with their time, employment would be answered no. Once they're deemed eligible for that, you can switch that to yes. And then where are you putting notes? So when you do your outcomes and you're checking yes or no, there's a little section below that that's for your notes. And you just put them in right below there. And then it shows up when we scroll over the C, like up here, we can see your note. And if you disagree with your admin's reconciled outcomes, please contact your admin right away via telephone or email. Is there any more questions? Those are good questions.
What about retirement?
Retirement, yes. Employment would be yes. Mm-hmm. Yeah. Yep. All right. And moving on past outcomes is billing. And so most of you or all of you recently got an email from Eric, and so yesterday. So I want to make sure that I'm very clear today. So if you're not listening, please listen. Are you all listening? Are we all listening? If you're not listening, please listen. Okay. So you need to complete your outcomes by no later than the 20th of the month. By the 20th of the month, you need to have all of your case notes entered. All of your chronos need to be done on the 20th, okay? Because what do we look at to determine eligibility for payment? We look at your case notes and chronos. We cannot reconcile for eligibility for payment if you're not done with those case notes and chronos. So we've been very forgiving and we've let people go back and put them in. We're not going to do that anymore, okay? We get stalled weeks and weeks waiting. So your outcomes are due on the 20th and all your chronos and case notes need to be entered by the 20th. Now, once you're done with your outcomes, your Free Through Recovery administrator will reconcile and complete a payment sheet. Now, these payment sheets will be returned to the provider between the 20th and 27th of each month. This month of December is going to look a little bit different because of the Christmas holiday. We're not holding anybody hard and fast to these 20 and 27 and 30th this month, but starting in June.
20th.
Yeah, the 20th we are, but not like your payment sheet might not be back to you by the 27th this month, okay? But so what we're going to do once we finish your payment sheets is we will send them to you, and the provider will have until 5 p.m. on the 30th of each month to verify those payment sheets, okay? So provider, you can keep whatever type of record you want, like your own ongoing spreadsheet, to verify what we sent to you. But you have until 5 p.m. on the 30th to email or call back and say, no, that's not right. It should have been this, or this looks good, okay? So we don't hear anything from the provider. We're going to assume it's correct, and we're going to be submitting it for reimbursement. Okay. So what do we have for questions?
If you're the admin, then you look at one versus the provider admin, or
You'll need to, the question was, if you're the admin for numerous regions, who will we send it to? In all cases, we're going to, your assigned administrator will send it to whoever you have communicated. Like if you want it sent back to the care coordinator that submitted it from that region, and you want it sent to you as the overall admin, you need to clarify that with your assigned administrator so that they know who that payment sheet can go to. It's easy for us to put multiple people on it, but we're only going to, send it to the people that we normally do or who we were told to send it. So make sure you clarify that with your region.
If the 20th falls on a non-business day or a holiday.
Saturday or Sunday, then they have to be done before.
Yeah, I guess.
Right. Yeah.
Are you seeing a month that's coming up in, or?
The question was if it, in other words, let's say that the the Saturday and Sunday are the 19th and 20th, then it's got to be submitted by the 20th. So you're going to have to watch for the weeks that happens, and you might have to submit them on the 18th, like on the Friday, just to make sure that happens. If your business does not do work on Saturday or Sunday, and you're not going to be accessing DOCSTARS, you're not going to be working with participants anyway, then you're going to want to make sure that that's documented on the Friday before, because the 21st, our admins will start reconciling, and whatever is not submitted at that point won't be considered in their reconciliation.
Any other questions? Oh,
I guess one other comment on that, we're not just doing that to like, many of you have noticed it's been harder for us to get payments turned around. We're reaching 1,300 to 1,400 participants right now. Admins are having to reconcile 300-400, plus participants. And the only way we can have that happen in a timely fashion for the whole state is to tighten up these marks. Both you guys tightening up yours and hitting those deadlines, and then we're going to be doing the same thing as an administration team.
Any other questions, Nikki? No? All right. So just covering what the payment sheet looks like. And what I said here is that when you get that payment sheet sent to you, don't modify the payment sheet. Just send the changes via email or telephone to your administrator. And the reason I say this is a lot of the payment sheets have those drop downs, and I'm noticing that those autofills and drop downs are kind of getting wrecked on some of the forms. And so just email or telephone your administrator with your differences, okay? Oh, all right, so discharge requests. So before you request discharge, you must have all your notes completed in DOCSTARS. Once the client is discharged from your caseload, you no longer have access to that participant. If your notes are not completed, your administrator is not going to go back and enter those notes so you qualify for payments. Okay, any questions? No? So discharge requests, please staff your discharge requests with your regional administrator and your parole probation officer. If there's been weekly attempts for 60 days, on the 3rd month, you're going to be ineligible as a provider, and we really are recommending discharge unless there was some sort of contact. During that time, you should be reaching out to that supervising officer. So if you've gone 2 weeks and you can't contact that participant, at that point, I would be, we're going to be looking that you're reaching out to that parole or probation officer. Not a generic chrono, text and call participant, can't reach them. Text and call participant, can't reach them. You need to be expanding your engagement and trying to connect with that person. In your discharge request, please fill in the comment section. One thing we want to clarify on is abscond. When you do not select abscond unless they have absconded from parole and probation. This doesn't mean that they've absconded. Some people are saying if you've kind of lost contact with them, you do abscond, but no. It's if they've absconded from parole and probation. And then if you see like a discharge denied from the DOCR, it typically means the DOCR is changing the discharge type, so our statistics are right, okay? And then the other one we want to talk about is when you select declined or stop participating. If the client stops participating because they feel like they have met their goals or they no longer need free through recovery, this is client driven. Remember, it's a person-centered program. That is not a declined or stopped participating. That is they completed the program. It's a successful discharge. And I think we could do a whole training on when is a good time for discharge, and we're running out of time here. But does client need or want the services? Are they connected to community-based services? Do they only want that once a month contact with you? Staff those with your regional, staff those with parole or probation. Is free through recovery what they need? The goal is really to connect and link people to their community-based services. That's under discharge.
Under discharge type.
Mm-hmm.
Yeah.
So when you're in that that assessment, right? Yes. So when you're in the free through recovery tab and you're under assessment, it's at the bottom of the page. I believe it's called request discharge.
And once you request it, it gives you these drop downs and gives the ability to add those comments.
I'll show you here. There you go. So the more comments in this area, the better, really. Okay. All right, so we went pretty much exactly an hour. If you need to go, I understand you can sign off. Are there any final questions? I think you can only select one type, but you can select multiple risks.
Or are we going up to?
Correct, case notes, chronos.
At the beginning,
Mm-hmm. Yeah, you can select more than one risk, but you cannot select more than one type, I believe.
I think there's only one, and then to select more than one on the area of risk, you have to hit your control button and hold it down while you select, and you'll see them highlight, and you can select multiple ones that way. Holding your control button down while you use your mouse to click on the different risk areas.
So what is that?
So the question was, what if the participant won't call you back? They don't want to participate in free through recovery anymore, but they're in a relapse. I would be, staffing that discharge, of course, with the parole or probation officer as well. And I think that, really does sound like a declined or stopped participating in free through recovery from my point of view.
And make sure that you go back to what Heather mentioned earlier as far as opinion. Like if you say they don't want to participate in free through recovery, don't put that in there based off the fact that they didn't call you back. It needs to be cited from them. Like, did they state that as a participant? Then that was their choice. You staff it with the PO. If their lack of engagement gives that impression, once again, that's an impression or opinion, still staff it with your PO, but we need to try to discern, whether they have clearly made a choice to withdraw from FTR.
I want to emphasize too, like case notes and chronos and why they're so important is if you're trying to attempt to call a client every week or multiple times a week, but then you write in one note when you have contact with the client, tried to reach the client all month and couldn't. We don't know if that's meeting that weekly contact standard. And so you got to think about it how we are deeming if you're eligible for payment when you're doing your discharge. So it's helpful if like every time that you try to reach that participant, you like put it in there, attempted contact, no show, because it makes reconciling at the end of the month a lot simpler, and we're able to see like, yeah, you're trying to reach that participant and you're not having any luck, collateral or, care team coordination, called PO, discussed with the PO, how client is currently doing, whatever, informed PO that he wasn't showing up to our meetings anymore. PO is going to attempt to reach out and engage with the participant, whatever it is. Okay, Nikki said it looks like we have a question coming in. Mm-hmm.
All right, so we're planning one yes. What do they enter the name?
You just change the name in there. You should be setting that person up with a new peer support specialist.
Yeah. And if you're working to hire, you should be working to hire peer support. You can reach out to Kelly Larson and through our Facebook page to find some of the different peer supports that may be in your area that are available to hire. There can be other ones that are used as a bridge. There are organizations that may be able to help do it short term, via someone from a distance, but the face-to-face is still the essential part of that. So, reach out to your regional or your FTR administrator to help with that. But we cannot give a list of the names. I think we've said that multiple times. So you can post something on the Facebook page saying that you're looking to hire a peer support, and then we're giving that Facebook page to everyone who goes through the state training. So. Care coordination team. The question was, is contact with the PO considered care coordination team as the type or collateral contact? It would be care coordination team. The PO is someone who's covered under those initial releases. And so the 3 people or 3 organizations are covered right away are your FTR admin, your probation and parole office, and your organization. So collateral is anyone else that you're contacting on their behalf. So it'd be someone like Heather said, a landlord, an employer, maybe you're calling resources, trying to find something like a bike or something like that. You're calling for things and you're considering it for gap funding. When you're calling other people on their behalf, then that would be collateral contact. Good questions.
Great. Anything else, Mickey?
No.
Do you want to come say hi? Wait, what? Well, Mickey's pretty great. Oh, yeah.
Yeah, as far as finding it after this, it will be posted on our behavioral health site under Free Recovery or under trainings. Also, as soon as we have it captured as a recording, we will send an email to everyone who registered for this training. We will send it to you along with the PowerPoint presentation itself too, so that you can use it for reference.
And our hope for these trainings isn't that every piece of this training is meaningful to you, but if you can just take out, 1 or 2 pieces and apply them to your work, that's really the goal. And we're just really grateful to have so many awesome providers doing such great things. And I think a lot of times with documentation, we know that the providers are doing a good job, but we also need to follow and do best practices and keep our notes up to date. We didn't talk about that, but just being timely. We shouldn't be, meeting with a participant and not having our notes completed from the prior week. We should really try to have those notes completed before we meet with them again, or their care plan updated, those types of things. And it's just best practice. And so, yeah, I hope we covered those pieces for you, and we will see you again soon. And the plan, like we said, is to continue to do this once a month. And so if you have team members that need to take this training, we'll get this finalized and sent out and put up on the website as soon as possible.
Thank you all.
Thank you.